This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon in New York and New Jersey.
And I'm Marina Kurian. I'm a minimally invasive and bariatric surgeon in New York City area. You know, Suju, we keep saying this, and you always keep yours the same, and I keep changing mine a little bit.
I know. I love it. I kind of learn more about you.
I'm trying to keep you on your toes.
I'm like, I wonder what she's going to say about herself this time.
Nothing but truth.
Welcome to our show. Welcome to She's on Call. Today, our guests are Dr. Camille Clare, who is an obstetrician and gynecologist at Metropolitan Hospital in New York City and Associate Dean for Diversity and Inclusion at New York Medical College, and Dr. Lillian Abo, who is an infectious disease specialist at the University of Miami Medical Center and Chief of Infection Prevention and Control and Antimicrobial Stewardship and core faculty on the Miami Transplant Institute team. And she's on staff at Jackson Memorial in Miami, Florida.
Yeah, and so we have a great show. We're going to get out and talk to them in a little bit. But first, Suju and I are going to do a rundown of the news of the day. And I'm going to let Suju start.
We're wrapping up Women in Medicine Month and with these two amazing guests, and we're very happy to have them. Please let your friends know by liking and sharing and tagging them on all the social media outlets so they can join in the conversation. So, you know, Marina, we talk about COVID all the time, and we're getting into flu season, and there's actually more evidence for wearing masks because the data is very clear that people can spread SARS-CoV-2, which is the virus that causes COVID-19, well before they show any symptoms of disease. So these are the pre-symptomatic and the asymptomatic carriers. And so these individuals should continue to follow those 3 W's, wear a mask, wash your hands, and watch your distance from others, while governments and institutions carry out testing, contact tracing, and isolation. And then we mentioned for a second influenza. So let's talk a little bit about how these maneuvers are helping us have a less intense flu season.
So one of my girlfriends had said, you know, we're probably going to see changes in other, you know, infectious diseases because of what we're doing with wearing the mask and social distancing, not going in. People are not actually going to work, right? They're all, you know, from home, and they're not going in when they're sick. So all of those things have a significant impact. And I had heard a couple of months ago, actually, that the flu worldwide was less, but now we have that great graphic showing that the flu is actually like just down at the bottom. You can see the curve, the solid blue line of 2019 to 2020, and you can see how it is at a very low percentage currently, where it would be a little bit higher now, because now we're kind of getting into flu starting, and it's going to be taking off in October, November, December, January, February. And so we're seeing that we're still at a much lower rate than it has been. And so that's really exciting and good news, because I think that'll definitely impact, you know, everyone's overall health. I mean, I'm actually thankful about the mask wearing. Sometimes when I'm not around anyone else and I don't have a mask on, I'm like, where's my mask? I should be wearing a mask.
So did you get a flu shot yet? I got mine on Monday.
I didn't because planning, laziness, something like that. But like if I walk into the hospital and they're like, do you want to get your flu shot? I'm like, yes, of course I do. Just roll up the arm right there, right?
Right, but that's what happened. Monday, a nurse came by with a tiny little needle and a beautiful flu shot, and I was done. But I think, you know, wear the mask, wash your hands, stay away from people when you're sick, but get the flu shot because this will really help. We really don't want a double infectious disease crisis on our hands. Marina, we talk a lot about what we consider the developed world or the first world in terms of COVID response. And there was a really interesting article on medium.com this week talking about the sort of bias in not looking at developing countries or countries where we think that they are not as advanced as we are. And frankly, many of those countries had a much more robust response in terms of the mask and the distance and the washing and the shutdowns than the West did. And there's a graphic we have up here that shows that these three countries, and maybe you want to talk about it, Marina.
Sure. So Mongolia has 3.2 million population, but 0 deaths, right? And
all those 140 cases were imported cases. They've actually had no local cases of COVID.
And Vietnam has 96 million, just over almost 1,100 confirmed cases and 35 deaths. And this is, if you look at Germany, which is a comparable country, 83 million people, but they had so many more cases and 9,500 deaths. So here are two countries that are almost the same in size, and yet, there's been a significant difference. And so their public health response is really to be lauded. And we don't have a graphic on it, but we mentioned it on a previous show about how Kerala was is a state in India, where I'm from originally, and my family's there. But that response there was so amazing that it set a benchmark for the rest of India. But I don't think all the other states took it because India is still seeing a fair number of cases.
Yeah, India is actually second in the world, only after the United States in terms of numbers of new cases, unfortunately. We had Ghana up there. So Ghana has about 30 million people, has had 46,000 cases and about 300 deaths. And, in resource poor areas, which I have to tell you, as somebody who keeps reusing her N95 mask at work, we're not so resource rich in the United States right now. But in resource poor areas, there are different ways to test people. And Ghana really employed something called pooled testing. So pooled testing means if you have 20 people and you do a separate COVID test for each one, that costs, 20x. It costs whatever a COVID test costs times 20. But if you have 20 people and you pool some samples from the first 10 in one batch and the second 10 in another batch, and you test that, if one of the 10s has no positivity, and this is a graphic about serum, but you can use it to explain this. So if the second batch has no positivity, then all those 10 people are negative. If the first batch has some positivity, you go back to those samples and you test them in now batches of 5. Again, if one batch is negative, they're done, and those people don't have COVID. If the second batch is positive, then you test those people individually. So that leads 20 people to be tested with only 9 tests. So Ghana instituted that very early, which was another excellent public health measure to keep this virus under control.
Let's, we had so many things to chat about, but I think we have to introduce our guests again. So
let me do one thing before we do that. And the one thing I want to talk about is licorice.
I know I wanted to talk about licorice too, but I
think it's an important public service announcement. So there was a report in the New England Journal of Medicine 2 days ago that a 56-year-old, really active, healthy man dropped dead after changing from red licorice to black licorice and eating 1 to 2 bags of black licorice a day for 3 weeks. So there's a component in black licorice, not in red licorice, that will drop your blood potassium level. And in fact, I didn't know this until today, the FDA says that if you're over 40, you should not eat more than 2 ounces of black licorice a day because you will give yourself risk for heart arrhythmias or bad rhythms in your heart. And that's only 2 sticks of black licorice. So that's our PSA for today.
I think that's spectacular. Hold on 1 second. Sorry. And that is it is a PSA, because you think, I'm a red licorice person. I never liked black licorice, and so I'm not surprised. I mean, I think it's dreadful what happened, and it is so surprising. And I think we say licorice, but what about those black jelly beans? But so be careful when it's Halloween. So be careful about, the candies that we're getting, because there's certain people that only get black jelly beans, right? So be careful. And that is important because of all the heart issues. But let's go ahead and introduce our guest right now. So we have Camille Clare, and she is an OBGYN. She's at Metropolitan Hospital, and she is Dean of Diversity and Inclusion. And of course, Dr. Lillian Abo is infectious disease specialist in Miami, and also works with the transplant team specifically. And thank you so much for joining us, you guys.
Thank you. Good morning.
Good morning.
Good morning. We're so happy you could join us. Just to remind our viewers, we are live on all the social media channels. We have two incredible, smart guests with us today. So please like and follow and tag your friends and share and join in on the conversation. We'd love to hear your comments and your questions and try to answer them the best we can. So Lillian, can we start with you? Can you tell us how things are going in Florida? You and I had communicated maybe, I'm thinking 3-4 months ago at the really height of the pandemic when everybody was just bewildered. And you have really maintained your cool and maintained stewardship of what's going on down there. Can you tell us what's happening on the ground?
Yes. So Florida has seen, and remember, Florida is a very large state, and in different parts of the states, we're seeing different things. I am in Miami-Dade County. Miami-Dade County started seeing the first cases in March. And then March, April, we were hit. We were in, preparedness, lockdown like everybody else. And then as we started to reopen, all the reopening plans were very thoughtful and were prepared. However, people around June started going a little on the wild side. We don't need to wear a mask, graduations. We had 4th of July. Everyone was running to the beaches and doing underground parties. And by the third week of July, at some point, Florida hit 15,000 cases in one day. That was on July 12th. And around that time and the week after, we were in surge. Really, all the hospitals in Miami-Dade County were facing, a lot of challenges. We had bed capacity, but the staff, nurses, physicians, environmental workers, everyone was burned out because since March, we never took a break. Things started to get better, and 3 weeks ago, we started to see around 4 to 5% of transmission in Miami-Dade County, and we were really optimistic and continued our reopening plans. However, already on Friday, things started to go above 5%, and now there is this mandate at the state level of fully reopening on phase 3. So I am concerned that we're still not where we were in May when we reopened. We still have a higher number of hospitalizations across Miami-Dade County, higher than what we had back in May. Things are better than they were in July, for sure, but this is not over. And we could be seeing the second wave very soon now with all the reopening. And I can tell you, I've witnessed already Friday night, restaurants packed, people in bars with no mask, all hoarding next to each other. It was really appalling. So we're here to see what's going to happen. But my message to everyone is this is not over. Even with a vaccine, it's not going to be over. And we really need to maintain our social distance or physical distance, wearing the mask and the hand hygiene, which are extremely important measures. And we're seeing countries like Israel that reopened, and now it's back to shut down, seeing the highest mortality and hospitalizations that they've ever faced.
Yeah, we're actually up here in New York. We're seeing those horrible chest x-rays again with the severe pulmonary disease. Ashish Jha, who went from Harvard to Brown, he's in public health at Brown, had a really interesting Twitter thread this morning talking about that post-Labor Day, that post-relaxation of requirements or relaxation of our feelings bump. And we're seeing it. Labor Day was 3-4 weeks ago, and we're seeing that increase in cases throughout the country. So I think please take heed to what Dr. Abo is saying, guys. Wear a mask, stay distant from people you don't live with, wash your hands. And even as you said, with a vaccine, which we're going to talk about in a little bit, that's not going to be as magic as people might think. Switching over to Camille, Dr. Claire, you practice the breadth of OBGYN, and I wonder if you can talk to our viewers and our listeners about what a woman should expect as a normal course of events during a pregnancy, be she low risk or when does she become high risk, and what are the things that have changed with COVID?
Thank you for that question. I would say that definitely in COVID times, we've really worked with our colleagues throughout the state to really focus on best practices of how to take care of patients during their pregnancies. Hospitals and birth centers are still accommodating patients, are still exercising the measures that we were doing before, way back in March. And so I think that's important. The other thing which has changed is really increasing use of telehealth, especially for prenatal visits. And so we're still seeing patients in person, exercising safety measures in person, and increasing the use of telemedicine, which has really been groundbreaking for our specialty and other specialties. So in between the tele visits, we're seeing patients in person. So that's really impacted their care. In terms of changing from low risk to high risk, that's very unpredictable and hard to really say when that exactly happens. There are many issues of why someone may become high risk during their pregnancy, whether it's comorbidities that they develop, diabetes, high blood pressure, whether it's their age, it puts them at risk, whether it's things that happen during the prenatal period, during the time of delivery or afterwards. And so it's really hard to say, well, there's one specific period of time that makes someone change from low risk to high risk. But the thing about our specialty is that we're prepared for that, so that if anything happens, and that's why vigilance is so important during prenatal care visits, as well as televisits. Patients shouldn't feel afraid that they can't come in to the hospital settings, because we're here to take care of you in spite of this situation with the pandemic. So not to be afraid of that.
I wonder if you can tell us, people, when should they start prenatal vitamins? What steps can a woman take to ensure that her pregnancy goes as smoothly as possible? Not, obviously staying away from people who are sick, but in the normal course of events.
Sure. I mean, ideally, in an ideal circumstance, before someone gets pregnant is a good time to plan for that. So speaking to your OBGYN, your OB provider, even before you actually become pregnant, 3 to 6 months or a year before, starting to let your provider know, I'm planning to become pregnant, that's ideal. We do know that 50% of pregnancies are unplanned. And so usually the time to start prenatal vitamins is even 3 to 6 months before you're planning a pregnancy. There's folic acid within prenatal vitamins, which is good to prevent certain birth defects in the brain and the spinal cord, which are called neural tube defects. So ideally, you can start that before becoming pregnant. And obviously, if you didn't plan a pregnancy, you can start that as soon as you get the news that you're pregnant. You can start that right away, even up to a few weeks or months after you deliver.
Thank you. I think that's really helpful because, you should, obviously you can't wait till you find out you're pregnant. You can, but you probably shouldn't, to start being as healthy as possible. I remember, I have 4 kids, and I remember that I went to a bar with my husband and some of our friends, and I didn't know I was pregnant, and I was freaked out because I had inhaled some secondhand smoke, and I was all about eating healthy and having my B vitamins and, drinking my milk. And, I think we become a little nuts when we're pregnant, but I think being a little nuts about being healthy is the way to go. Lillian, we have some questions for you about your role in the transplant team and antimicrobial stewardship, but we do have some questions coming in from our viewers about testing. And I wonder if you can talk to us about COVID testing. I wonder, we talked about pooled testing in the beginning, individual testing, antibody testing, and then even wastewater testing. Can you speak to us a little bit about that?
So I'm going to talk more about what the layperson needs to know about testing and some of our physicians, because there's still a lot of confusion. There are different ways of testing for SARS-CoV-2. We have molecular tests, which are the ones that extract the RNA, what we call the PCR, polymerase chain reaction, and those are what we call now the gold standard. This is a virus that you can culture also, but it's very hard because it's so transmissible. You need a special biosafety level hood. For example, Florida doesn't have one. So in order to do cultures, we have to send it to the CDC. So culture is something that exists, but it's not available to everyone. Commercially, and in most of our hospitals, what we use is the molecular test, which is the PCR. And these PCRs, there are different platforms. There are some that you get your results in 30 minutes. There are others that you get it in 2, 4, 6, 12 hours, depending on the turnaround, on the lab, and the lab capacity. Besides the molecular test, one thing that people need to understand with a molecular test is that it can detect the presence of the virus, whether that virus is infectious and you can get sick from it, or it's just that you have present detectable virus. It's something that it's a little challenging. And we measure something called the cycle time, which is how many times the machine has to run it in order to detect the virus. So what we know from these molecular tests is that people usually, after 10 days, or if you're critically ill more than 20 days, you're less likely to be infectious. But the test can stay positive up to 90 days, 12 weeks. So that's one challenge with the moleculars. They can stay positive for a very long period of time, but doesn't mean that you're actively infected or infecting others. The second test that we have that you mentioned is the antibody test. And there are different types of antibody tests. You can detect IgM, IgG, IgA. And what that tells us is doesn't really tell us if you have an active infection. It tells us more you've been exposed to the virus. And we're doing those tests in people who say, hey, I've had symptoms, I recovered, and now I want to know. Or some people never had symptoms and we check their blood and they have antibodies. That is important because we are encouraging people who have antibodies to go and donate plasma, convalescent plasma. The other thing is we don't know if you have immunity from this virus. So we don't know if having antibodies really correlates that, you're out of the woods, you're safe. But the antibodies is what we're actually using to prove that the vaccines work. So we do want to detect an immune response. The third test that we have now that are becoming more common now is the antigen test. The beauty of the antigen test is it's not as sensitive or specific. It means that it's not as accurate as the PCR that I mentioned first. It's a test that you can do in 15 minutes or less. You just swab the nose. You don't have to go all the way to the nasopharynx. And we can do it as a point of care. A point of care means that I swab your nose and in 15 minutes I can give you the result. It's cheap and it's something that we can escalate and adapt very quickly. If you have a low prevalence of disease, it's good. And I think that's where we're trying to move towards, especially in developing countries, opening schools, airports. Eventually, that's what we need. A test that is good, that it's cheap, and that can be, adopted very quickly, that you don't need fancy equipment in your laboratory. So right now we have those three, I would say modalities of testing. And then what you mentioned, it's water testing and environment testing, which is, that's a different story.
That's terrific. That is the best breakdown of testing that I have heard. And I have been looking at this, since the beginning of the pandemic and certainly in detail since we started our show in June. So thank you so much. My son's up at college and they do nasal swab testing twice a week up there. And I think many of the colleges, perhaps all of them, are really instituting conditions of testing so that these young people can be back at school, maybe not in the classroom, but in their pods together, experiencing a learning experience that helps them. I want to thank everybody for their comments and their questions. We have people commenting from New Jersey and from Florida and from Long Island and from California and from Delaware. And I want to say, please like and share and tell your friends. And if they missed what Dr. Abo and Dr. Claire just told us, please have them go back and watch us later because it's really gold. In medicine, we call them pearls of information, but maybe they're titanium or unobtainium, something amazing that you guys are giving us. Camille, let's talk a little bit back about gynecology. So, we'd like some advice. When is the correct age for a girl or a young woman to start seeing a gynecologist? What are you guys looking for? How often do we get pap smears? What's the regimen that we should follow as preventative to maintain our health for as long as we can?
So the American College of Obstetricians and Gynecologists, of which I'm a member, recommends that a person should start to see a gynecologist in between the ages of 13 and 15 years of age. That doesn't necessarily mean that an exam is the time that happens, but that's the ideal time to start to talk to a gynecologist. In terms of pap smear testing, the recommendation now is 21 years of age to start testing. And the timing of when to start testing really depends on the type of test. It can be confusing even for us as gynecologists to know, is it HPV testing alone? Is it a thin prep or pap smear test in and of itself in combination? And so there are recommendations for that. So I would definitely advise folks to look at ACOG for those recommendations, as well as ASCCP, because those guidelines do change very often. And so those are some of the guidelines as to when to do testing. Roughly, testing should stop at age 65. However, we do know, depending on certain risk factors, previous history of abnormal tests, for pap smears in particular, that may be longer than that. So again, really, in terms of physicians that may be listening, to follow those guidelines, and for patients who are listening, to talk to your OBGYN to see what is the recommendation for yourself. I see this great infographic on the slide in terms of what you're looking for in terms of your pelvic examination, which is done. You may be examining the size of the uterus, you're examining the ovaries, you're doing a breast.
I think we're having a little bit of, we had a little audio. So go ahead, you were going to finish, because I think that's great information.
Okay.
Oh, something happened to Camille's audio. All right,
No.
we're gonna go forward from there. I thought that graphic was beautiful.
What about the? Ooh.
What about the?
Perfect. You're back. We'll go forward, but I think that graphic that was just up and Dr. Claire's explanations of it are really important. I think, we need to start taking care of ourselves in every way, which is sort of the crux of having a show like this, where we talk about different aspects of healthcare. Both of our guests and Marina and I are very passionate about healthcare disparities, and we know that COVID-19 affects people of color much more aggressively than it affects white people in our country. And the CDC looked at 392,000 known COVID cases and 121 deaths from children from February to July. And what they found was that 75% of the children killed by COVID-19 were Hispanic, Black, or Native American, American Indian, whereas those children really only make up 41% of the U.S. population. And the graphic that we're showing now shows the very disproportionate hospitalization rate for children who are Hispanic or Latino or Black compared to white children for COVID, which means that their severity of disease is worse. And I know both of you practice in areas that are very diverse. And I'm wondering, Lillian, if you can talk to us a bit about what you're seeing in terms of ethnic changes or ethnic differences in COVID-19.
So I think there are a couple of points that need to be made about these data. First thing, we're in Miami again. So Miami, we have a prevalence of a very high prevalence of Hispanic, multi-generational communities. And we also have, African Americans and people from Haiti, from the Caribbean. So what we are seeing is, yes, a majority of our hospitalizations and critically ill patients has been in Hispanics, but that's also the population that we serve. And Jackson Health System, where I am at the university, it's the county, it's the safety net. So we have a very high percent of indigent. We have a high percent of people that are immigrants. We have people with no insurance or Medicaid. So it's the demographic of the population we serve. When we have done some preliminary analysis, and we have a group of public health and critical care who are looking at these factors, we're really not finding that it's the race. It's not being Black or being Hispanic. It's really more the comorbidities, the access to healthcare, it's sick people showing up to the emergency department very late for multiple reasons, some of them living in multi-generational homes. And that's what we're seeing. Earlier in the pandemic, back in March, we're seeing a different demographic. We were seeing people who had a history of travel or were in contact with someone who had traveled to Europe or Asia. Now, in July and August, what we saw was what I'm explaining, which is if you have diabetes, hypertension, heart disease, people that are nursing home residents with multiple comorbidities, or children who have underlying medical illnesses, they have a higher prevalence of getting critically ill or death compared to children, regardless of the race, that don't have those comorbidities, or those adults and elderly that don't have the comorbidities. So I think we need more information that if it's truly the race or it's the comorbidities and the access to healthcare and the socioeconomic factors, that it's really playing a role. What we're seeing in Latin America, it's, Hispanics in multiple Latin American countries. Peru right now has one of the highest mortalities. I don't know if it's just being Hispanic or it's really, again, the access to healthcare, how fast you go when you're sick, and what are your comorbidities.
Thank you. I think that's really very helpful. I know you're from Venezuela originally. It's a beautiful country. I miss travel so much, and I'm so grateful that I took the opportunity to travel when I could. Can you tell us a little bit about your experiences in Venezuela? Not just how gorgeous it is, because it's gorgeous, and when the travel opens, I recommend people go there. But tell us about healthcare down there.
So unfortunately, Venezuela is right now in a very challenging situation. Venezuela for the last 15 years has gone from democracy to a left-wing government that has implemented communist measures, hiding the true numbers. And unfortunately, in Venezuela, people don't really know what's really happening, as many of these things are not public information. It's very sad. They have the highest death in healthcare providers. Physicians pretty much don't have access to PPE or masks or gowns. Many parts of the country don't even have water or electricity or gas to transport patients. So it's very challenging. We have two realities, the public health system and the private hospitals. And really, I applaud the hard work that my colleagues are doing in Venezuela, because people are really giving everything they have to continue to save lives and to protect themselves and their patients.
Thank you. It is a plea for the world to understand what harsh conditions patients and physicians and nurses and caregivers find themselves in. As I said before, we are live on all the social media platforms: YouTube, Facebook, LinkedIn, Twitter, scroll.in, and please tag and tell your friends and like and share, because wow, when do you get to meet such amazing women and spend an hour with them? Let's go on to vaccines. So we had talked about the preventative measures and we had talked about vaccines. And before we get to COVID vaccine, I'd like to talk to Camille about HPV. So HPV is human papillomavirus. And I'm really impressed that ACOG has done this incredible outreach to the community to explain the importance of HPV vaccine. And I'll tell you, as an ENT surgeon, it's important for men as well, because we are seeing throat and tonsil and base of tongue cancers that are caused by HPV, when 20, 30 years ago, they were all only occurring in people who were smokers and drinkers. So,
like Michael Douglas, right? Michael
Douglas. And in fact, one of the spokesmen for HHS, Mr. Caputo, just took a break from his duties to take care of his throat cancer, judging his age and his non-smoking status, it's most likely an HPV. I don't know that for sure. But maybe, Camille, you can talk to us about what and when and how we should vaccinate our children.
Yes, so I do not see any children in my practice, but we do recommend, and our pediatric colleagues are really doing this, starting at age 9 or 10 for boys and girls to start their vaccination up to age 26. There are some studies that have shown up to age 45, actually, you can vaccinate someone if they haven't previously been vaccinated, but the original studies went up to age 26. So it's definitely recommended. There are many types of cancers that HPV can cause. As you mentioned, the head and neck cancer, cervical cancer, there are hundreds of different types. And so definitely recommended to at least prevent, as the slide mentions, over up to 90% of cancers that are caused by HPV, anal cancers as well. And so it's really, really important. I see obviously primarily women, but for those providers that are seeing boys and men, that's when it should be recommended for sure.
You know, I vaccinated my kids, and I talked about this on my radio show many times with HPV vaccine and how important it is. And I think the biggest point is that we are preventing future cancers. We're saving girls and women from cervical cancer. And when they expanded it to 45, we got a call in from a bunch of 50-year-olds, men and women. They're like, well, I'm about to, they're getting divorced. They're going back out dating. They're like, should we get the vaccine? And then do you guys know Jen Gunter? She's,
yes.
Yeah, so she's a GYN, huge on Twitter, one of the Twitterati, and actually has a show, I believe, on cable that is all about, I think she wrote the Vagina Bible or something like that. But she, at age 52, she went through, she actually took the vaccine. She tweeted about it, and I think she wrote an article about it as well, because she was also, I guess, re-entering the dating pool. And so while all that is soft data, right, Camille, I'm sure you'll say, it's still an interesting concept and still shows the concern people have. And I think I had talked to a colorectal surgeon about the HPV vaccine, and she was like, absolutely, this is going to help with anal cancers that present, because as she put it, once the vaccine's down there, it just moves around. It's not like it's limited to one, system. So it can actually it's so close in proximity in the perineum that it can actually move over. So it is, it's going to save a lot of people and a lot of cancers. And I think I just don't even see the reason to not take them. And they were are they still 3 doses? I think that they were 3 different times that we had to vaccinate.
Yeah.
My kids just went right in and took it like champs.
Yeah. Ideally 3 doses, but they've even shown up to 2 doses have been effective. So I can't speak to beyond age 45. We really don't have the evidence for that, but definitely up to age 45 at minimum of 2 doses, ideally 3 doses, but 2 doses have been shown to be effective for the HPV vaccination. So we definitely recommend that. And if you weren't screened, or if you didn't receive the vaccine earlier in your life, you can still receive it as soon as you are seeing a provider, and any provider can give it. So recommended for sure.
Thank you. That's terrific. Thank you for the nice comments that are popping up on the screen. These are really very important and useful information. Lillian, let's go back to you and talk a bit about where we are in terms of development of a COVID-19 vaccine. And we do have a question. So I got my flu vaccine this past Monday, but one of our viewers is asking, they're planning to wait until October 15th. And is there a role for waiting a little bit later in the flu season at this time? So maybe we start with flu and we go on to COVID.
Okay, so regarding the flu vaccine, I personally already got my flu vaccine. So I'm a big advocate of getting your flu vaccine early. It takes about 2 weeks to develop antibodies and immunity. We know the flu season starts already, September through November. We started to see, depending on where are you in the world and in the United States, you may start seeing flu cases earlier or not. And again, it also affects the human behaviors. These are the social determinants of health. Are people wearing their mask? Are they social distancing? Or are people partying and going everywhere? And if that's the case, the sooner you get your flu shot, probably the better. But it's a personal decision. If you want to wait until October, there is nothing wrong. But I would say to people is don't wait until November, December. I would say try to get your flu shot earlier. We never know when we're going to see it. And, there have been rumors that, we don't know if the efficacy will last. We also don't know how effective the flu vaccine will be. So it depends on what strain is circulating. But I would say get it sooner rather than later, especially if you have risk factors, healthcare workers or elderly or children.
And then can you talk to us a bit about what's going on with the COVID-19 vaccine or the SARS-CoV-2 vaccine?
Sure. I think there are a couple of infographics because there's a lot of information and a lot happening with the COVID vaccine development. We know that there are at least right now 170 vaccines that are in the pre-clinical trial. There are 10 in phase 1, 15 in phase 2, and we know that there are 9 vaccines, at least 6 of them in the United States, that are on phase 3. What does it mean on phase 3? That you're testing these vaccines of thousands of people to make sure the vaccine is effective and safe. Safety here is the catch because we've been dealing with this pandemic now for 9 months. We don't have years of experience to know, what will be the long-term side effects. We don't even know what are the long-term side effects from the virus, yet imagine the vaccines. The important thing here is that we know that we're going to need more than one vaccine. It's impossible for one manufacturer to cover the entire population of the world. Just in the United States, most of these vaccines, not all, but most, are requiring 2 doses right now to prove that you develop actual immunity. So if you multiply the population of the United States times 2 vaccines, you're going to need at least 7 million vaccines. If you multiply the population of the world, you're talking about 7.2 billion people that would need to be vaccinated. We know that definitely we're going to need different manufacturers and to scale up to reach whomever we need to reach around the globe. We don't do anything by controlling the pandemic in one country and doing amazing and let the rest of the world be on fire, right? So that's one point. I think there is another slide showing the different types of vectors and vaccines. So there's some vaccines that are using viral vectors like adenovirus. There are others that are using an inactivated virus. And now we have the DNA and the RNA vaccine. These are vaccines that have not been used before, that were not approved, but now 2 of the manufacturers are really using these DNA and RNA vaccines. What you need to understand for the non-infectious disease person, and by the way, there was yesterday a phenomenal call with the CDC and the ID Society of America. If anybody wants to watch that webinar through the IDSA, it's available for free, the recording, and it was phenomenal. They explained from FDA, the safety, and what are the measures that we need to take to ensure that vaccines are safe, that we cannot bypass any steps, and what are the differences between the vaccines. What we know from this DNA and RNA is they're very immunogenic. What it means is that once you get the vaccine, you may have malaise, fever, some, weakness, tired, so you develop an immune reaction, and that happens with first or with the second doses. With the adenovirus vaccines, there's some concerns, and here you have an infographic on the RNA vaccine. So it's really how you're using the spike protein and how you're entering the cell. And I don't want to go into too much detail for the lay people, but it's pretty much you are creating this infection using a vector that it's an RNA virus. These ones are easy to manufacture quickly. So that's why they're going first with these vaccines, which have not been previously approved. But the concern that we have is what are going to be the side effects from these vaccines. And that's where everybody's paying attention. It's not just developing immunity, but you want to make sure whatever we put in, it's safe for the public. And that's where we're putting a lot of pressure on the FDA to make sure that in this, race for the vaccine, we don't, bypass any steps. For example, the Russians did not do the phase 3. They just went out and implemented the immunization, and they're doing a live phase 3, pretty much seeing in real life what's going to happen with the vaccine. So that's a bit dangerous. And I think we're doing the right thing here by let's do it well. It's not just rushing and getting a vaccine. Let's make sure the vaccine works.
Lillian, are there successful RNA vaccines right now? My impression was that there are not as many RNA vaccines, and that's why this is being watched.
So there had not been previously approved. So all we have used in the past that the FDA has approved, the current vaccines that we have, measles, mumps, influenza, they're not RNA vaccines. So the Moderna is an RNA vaccine. Pfizer is using an RNA vaccine. And for example, AstraZeneca is using a viral vector, which is an adenovirus. So AstraZeneca had to actually stop their trials in Europe and the US because of a side effect, a neurologic side effect, and now they're resuming. And there is some concern in the medical community when you're using adenovirus vectors because your system is not just responding to the vaccine, it may be responding to the vector as well. With the RNA
Lillian, can I just say for our viewers and for our listeners, a vector is the way the material is carried into the cells. So can you step back and just explain what that vector word means?
So I would say, let's put dengue, right? So you have a virus and you're going to infect somebody with dengue, you need a mosquito. So the mosquito is a vector. It's what's transporting the virus, infecting, the human. In this case, when you're talking about vaccines, they're using a viral vector. They're using a virus to transport this RNA that is going to generate antibodies. Once you get what's the goal of vaccinating someone? That you develop an immune response. So in order to get this to your cells, we need to use different transporters or vectors in order to get that piece, of RNA into your cells to say, hey, immune system, recognize this and start producing antibodies. So we create sort of like a fake infection. We fool your immune system to think that you're infected, but what we want is to produce antibodies to be able to fight the infection. So that's in lay terms what we're trying to explain here. And that's why there are different candidates. They're using different transporters to try to target different parts of the virus for us to develop this antibody or immune response.
And then I think the other challenge is, of course, getting people to take the vaccine. As you said, in Russia, they seem to be doing a real-time phase 3 study. I heard in China, they're also doing a real-time sort of just inoculating people. But as we talked about with HPV, it really took physicians and organized medicine to educate people to understand the importance of taking a vaccine. And my cousin actually found this incredible picture, and this is from Karnataka state, Mysore state, which is the state my family is from in India, at the time of the Raj, at the time of the kings. And the three women pictured here, the middle woman is the grandmother or the mother-in-law, and the two women are two of the wives of the king. And the young woman who has her left upper arm exposed, which would never, ever, ever happen in a modest woman in that era. This is from the 1800s. She is showing her left arm to indicate the safety and need and efficacy for a smallpox vaccine. So this is possibly the first real PSA that we have from the 1800s, encouraging people to be like the queen and take your smallpox vaccine. And I think we really need to think about how, as you said, Lillian, when things are safe and effective is when the population will use it. We actually have a question from a viewer about the efficacy of polio and yellow fever vaccines. So are there vaccines are they RNA vaccines? I think is Julia's question.
Yeah, but it's not if it's an RNA or DNA vaccine. It's actually the vector, the way we're using for this. So some of these are live attenuated, like polio. We had the Salk and the Sabine, right? So one was dead virus, the other one was live attenuated virus. So those vaccines have been very effective. What is different now is the transporter, right? So that's, I think, where it's a little bit different. It's not RNA virus or DNA virus. It's really the mechanism of how we're using, the vaccine. I think one important point that I want to make, because there's a lot of questions about flu. 1918 was the flu pandemic, or the Spanish flu. The flu pandemic killed more people around the world than World War I and II combined. And we are 100 years later, and people still say, oh, I don't want to get a flu shot. I get a flu shot and I get sick. Now we're living the COVID pandemic. Imagine 100 years from now, people saying, oh, no, I would never get the COVID vaccine. So I think we need a couple of things. People are in a rush. They want to get this solved. We all want to go to our life, traveling, business, going to school, and going back to a new normal. We need to do things safely. We need to have credibility. And that's why I keep saying, the FDA is looking for at least a 50% efficacy in a COVID vaccine. Of course, all the companies want to get 100% vaccine efficacy, but the minimum is 50%. I keep saying we need to continue the measures that are working. Even with a 50, 60, 70% effective vaccine, look how many billions of people we need to vaccinate around the world. We really need to do this in steps, and we really need to prove that the vaccines not only develop immunity, but that we don't have adverse side effects that will cause harm. And that, I think, is an important point. You have the flu shot. We know that it's a pain in the neck that you have to get it every year. I think everyone is working on trying to get a universal flu vaccine that we just get vaccinated once and that's it. And I think that's what we want with COVID. We don't want to get 2 shots. Like with HPV, we want to get 1 shot. So I think...
But Lillian, with the flu shot, it does vary through the season as different strains kind of take over. So, what I try to tell people is take the flu shot because it'll help ameliorate. If you do, you can still get the flu, even if you had the flu vaccine, right? I mean, that has something to do with how the flu changes during the course of the season and from what you got inoculated with at the beginning of the season. But it's still important to get the flu shot. Like I get it every year, and it's so rare for me to get sick during the flu season. Like I had a fever in February one day, and I thought, oh, maybe I had the flu or something. I probably just had like something rando, right? Just something. It was like a 24-hour thing, and it went. And then later when COVID happened, I'm like, I wonder if this was, and of course it wouldn't have been, right? Because COVID at that time, I feel like that strain was super strong and the people were so sick when they got it. But now we're finding, there was a theory out there, and I'd be interested to hear what you thought, Lillian, that the COVID that we're seeing now is a mutated strain, because these viruses do mutate compared to what was originated, in December 31st in Wuhan.
There have been hundreds of mutations already, but they're not major mutations. And I can tell you from personal experience, I'm still seeing people, including healthcare workers, who are wearing all the PPE, but then they go on the lounge to have, food together with their, colleagues, and boom, they come back infected. I have young people hospitalized. We've had multiple patients who have required lung transplants around the country, people who are having severe lung damage. This is still, even if there's some mutations, we're still seeing severe cases and people dying. So I don't want to create panic, but I want to create awareness that, no, this is not just a mild cold, that everybody's going to be fine. Some people don't have a single symptom. Some people just have anosmia. They lose their smell and they're going out and about with their lives. And there are others still very young who are coming in extremely critically ill.
Yeah. And
I think we can't minimize that. Just to jump back to Camille for a little bit, we're getting close to the end, and this is an amazing, wonderful conversation. We have about 8 minutes left. Camille, can you talk to us a bit about ectopic pregnancies and what somebody should look out for with that? And can you also talk to us about, are people actually delaying necessary care for OBGYN complaints? Because we did see a study come out of Dartmouth that said that hospitalizations during the pandemic for non-COVID reasons were down 40 to 50%.
Thank you for, it's a little bit of a deviation from what we were just talking about, but an ectopic pregnancy is a pregnancy that is outside of the uterus. So most commonly, it can be located in the fallopian tubes, and that's dangerous. It's life-threatening. So someone can be pregnant. They may have some bleeding and pain. And the most important thing that we do is to check a pregnancy hormone level, as well as correlate that with an ultrasound to make sure that the pregnancy is located in the uterus, which is the normal location. And if it's not, then we need to figure out whether someone needs to be taken care of by medication, depending on a list of criteria, or by surgical management. So if someone finds out that they're pregnant and they start to have any bleeding or any pain, it's good to see a healthcare provider, an OBGYN, to make sure that they don't have an ectopic pregnancy. Now, the other question was, can you repeat that one more time?
Delay in
care. Yeah, thank you. So, I think emergency, or what is called essential care, was going on the whole time. So patients were being taken care of for obviously anything that happens in their pregnancies. If there were any essential surgeries or emergency surgeries, they were being taken care of. So I think that wasn't delayed. I think with telehealth, we were able to appropriately triage people that needed to be seen in person versus those who we can take care of by a phone call or video conference. So I think we're seeing the impact of that delayed care now. And so what we were able to do was go back, even in our own practice, go back and look at patients that, we couldn't get in right away to have their surgical procedures or to have certain care measures. Looking at our own patient lists and our patient panels to make sure that they're getting in right now. So we will see that going forward, any impact of delaying care or reducing the time frame for when care was needed and when it was actually obtained. And we will continue to see that. So it's very, very important for sure.
So, we are running out of time. Lillian, do you have any takeaways, like your top 3 takeaways for our viewers?
Well, I think that, mentally we all need to take care of each other. I think this pandemic, we don't want to end up with a psychiatric pandemic after, all these months. This is a marathon. This is not just a race. We all need to pace ourselves, take care of each other, take care of your families, your friends, be kind to yourself, and understand that, yes, we're all going through this together. We're all going to get out of this together. Stay outdoors when you can. If you can, avoid indoor spaces with poor air circulation, that it's critical, to your safety. Keep wearing the mask, get your flu shot, keep your hand hygiene and your physical distance whenever possible. And, thank you for the opportunity for being here today, and to all of you for being a great audience.
Thank you so much. Before we ask for Camille's final 3, I want to say we have so many wonderful comments coming in. Nancy Ross, who works in television, thinks we have a great show with great graphics. So, woohoo, feeling pretty good about that. People are watching again from all over. The CDC just said no to Halloween and trick-or-treating. And people are very concerned about what happens when you're outdoors at a cafe that's outdoors, but we see in Manhattan, people are smashed up together outdoors without masks, or you're walking in the street and it's crowded. How safe or unsafe is the outdoors, Lillian?
The outdoors are safer than the indoor. But again, if you're outdoors, crowded, not wearing a mask, we saw this during the protests earlier in the year. And we have seen it with, at least in Florida, we saw it during 4th of July and potentially Labor Day. So I would say, even if you are outdoors, unless you're jogging, or biking on yourself, try to wear your mask. I know sometimes it's hot, sometimes it's difficult. If you are with your household, it's safer. But if you're people that are not from your household, you really need to keep the physical distance and stay safe. And I think Halloween, my kids are bummed. We're all expecting to go trick-or-treating and showing off their costumes. I told them, hey, this year is this. It was worse when our grandparents were living in the Holocaust, in the World War, and they survived. So we all need to put things in perspective. It's a bad Halloween. Next year will be better.
Somebody said, I think it had to be on Twitter, that Halloween is like the perfect solution for COVID, because you're wearing a mask,
Right.
and you're walking around outside, and then the CDC totally came down on it. So, unfortunate, because
I think we're worried about the Halloween parties too, right?
Yeah.
So I think that's a concern. And also, you don't want to be sharing candy and touching the same bag of candies that everybody's touching. And the kids are taking their masks to eat the candy while they're trick-or-treating. So I think is a challenge.
So Camille, can you leave us with 3 takeaways that you'd like our audience to keep in their minds?
I think as an OBGYN and for women to really be aware of things that are important to them, to their own health care, be able to have a list of questions to talk to your OBGYN about regarding during your pregnancy or even beyond the period of your pregnancy into menopause throughout your life. We are the providers that take care of women from early on in their life all the way to the end. And so I think That's really, really important. There's so many issues that we tackle today, some related to COVID, some not related to COVID. But the most important thing, any questions you have, being able to talk to your OBGYN provider about those questions, anything that you have, we're here for you. We continue to take care of you, and we'll continue to do so. And working with our colleagues, we're a specialty that works with all of our colleagues, especially during these troubling times, to make sure our patients are well taken care of. So that would be my take-home advice. And thank you again so much for the opportunity to talk to you about what I do for a living and what I love. Thanks a lot.
So, we want to thank you both. So Leland Abbo, who is at Jackson Memorial and University of Miami, infectious disease specialist. Camille Clare, you're the Associate Dean of Diversity and Inclusion at New York Medical College as well. You're at Metropolitan Hospital, OBGYN. Thank you so much for joining us. We want to thank our producers, and also we want to thank WBAI because they carry our show on the radio on Mondays from 2 to 3. So that's fantastic as well. And also stay tuned because next week's Suju, what do we have?
Our show will be all about radiology, so
right.
All about x-rays. Our guests will include Dr. Agnieszka Solberg and Dr. Taj Katapuram, and we are really looking forward to exploring everything there is to know about those amazing x-rays that Marie Curie won her first of 3 Nobel Prizes for discovering, along with Henri Becquerel and her husband Pierre Curie. So we're very excited about
her hand too.
Huh?
We'll talk about it next week.
We'll talk about it. She's my hero. I know everything about Marie Curie. Don't worry. I got you. And we want to say to our guests, thank you so much for wrapping up Women in Medicine Month with us. Yeah. You join a huge cohort of our guests. 24 now of our 27 guests have been women, and incredible, extraordinary women who are providing compassionate and comprehensive health care. And we are so honored that you joined us today. Thanks, everybody. Happy Hispanic Heritage Month. Happy Women in Medicine Month. Stay safe and stay healthy.
Bye.